Welcome everyone. Thank you so much for joining us for this lunchtime lecture. Today we've got Dr. Karen Elliott and Helen Gilthwaite joining us. They'll be presenting on SMART, an investigative assessment creating a profile for the PDOC patient. We will hopefully have time for questions at the end of the talk. So if you do have any questions, please do use the Q&A button. It's probably at the bottom of your screen or to the right-hand side. And we will get through as many of your questions as we can at the end of today's lecture. Without further ado, I'd like to hand over to Karen. Thank you.
Hello, hello and welcome everybody that's logged in. We've got quite a range of people that are joining us today. So we have clinicians, case managers, solicitors and lawyers. So lots of different backgrounds, which is fantastic. And we're delighted that so many people have been able to join. We all refer to PDOC clients, patients in a different way. So for ease of the talk, we're going to talk about the individual in a PDOC as a patient throughout. And we're going to talk about families, but that's families in the widest context possible. So it relates to anybody that has a significant interest and connection with the person in PDOC. So they're just global terms. Okay.
Oh, Karen, in the first instance, if you just use the arrows in the bottom left-hand corner.
Right, yeah. Thank you, Anna.
That's all right.
There, Anna. Thank you. So what we're going to attempt this afternoon in the next 45 minutes, we're going to talk a little bit about our background and the terminology that we're going to use throughout the talk. We're then going to really focus on the development of SMART as a clinical tool and how we developed it and how it has the elements that we have now. And that's going to form the part of the investigative process, which are all the parts of SMART and how we use those to create a profile for the person in a PDOC. We're then going to go on to what we do with that information, and that's primarily taking it into formatting intervention and management plans. And at the end, we're going to talk about what's quite a hot topic really in the PDOC world, which is about tool selection. We're going to talk obviously about SMART primarily, but it's also about deciding which tool is best for your particular context and your particular client, and we're going to address that a little bit at the end. So just thinking firstly about our background, Helen and I are both from the RHN originally. Helen still works there 1 day a week. I first started at the RHN a long time ago, so we're talking about 1987, and the brain injury unit started in the RHN at that point, and it was a pilot at that time. It's the first brain injury unit in the UK. We had a number of patients admitted to the unit. Most of them were in vegetative state, and at that time there was very little known about vegetative state, disorders of consciousness. There wasn't even a diagnosis of minimally conscious state at that time. And so it was really important to develop a clinical tool. And that's what I set about doing in my clinical practice, was looking at how we could assess what these individuals were able to do and then what we could do with it. So trying to understand a little bit more about the individuals. We then got involved in research to try and justify what we were doing and also give some evidence to what we were doing clinically. Helen joined the RHN and we worked together on research, and then Helen went on to carry on the research to validate the tool. So we've been working on SMART on and off for a long time, and we're now on version 3, which we brought out last year. So we're going to talk about the development of SMART, but also some of the changes that we've most recently done. Helen now works 1 day a week at Putney, as I said, and we've also got our own company, Gilthwaite and Elliott, where we specialise in the management and assessment of patients in prolonged disorders of consciousness. So we do a lot of assessments, we go all over the UK, and we also teach on the SMART. We run the SMART courses at the RHN, and we support all of the clinicians that are going through accreditation process. Helen and I have also been lucky enough to be part of the working party for the Royal College of Physicians guidelines in PDOC, and that was in 2013, and the current ones, which are 2020. And we will be referring to the RCP guidelines as we go through. If anyone's not familiar with those, you can download them from the RCP website. They're the PDOC guidelines, and you have a document of guidelines which can guide your practice, but also on the website there's a series of annexes that we will refer to today, and they're about practical tools that you can use in your practice to check checklists and things that you can use with families. So it is well worth looking at that resource. So on to PDOC. PDOC is prolonged disorders of consciousness. It's an umbrella term for a series of diagnoses, and those are coma, vegetative state, and miliary conscious state. Coma is the first condition that occurs usually after somebody has had a really traumatic brain injury. It lasts for about 6 weeks, and the primary tool that's used at that point is the Glasgow Coma Scale. So that's a tool that will monitor sort of changes, and it will also highlight if anybody is deteriorating in terms of their brain function, if there's any secondary damage occurring. So that's a really important tool that's used early on in the acute stages. What happens after 6 weeks is somebody will either start to emerge from a coma, or they will progress into a different state, such as vegetative state. So that would be where they have a disorder of consciousness, but their responses are slightly different from those in a coma. Somebody in a vegetative state doesn't respond to anything in the environment or that's happening to themselves. Miliary conscious state is another diagnosis which might occur on from vegetative state. Not everybody progresses along this spectrum, but some people do. Some people may stay in vegetative state. Minimally conscious state is somebody that's aware, has an awareness of themselves or the environment, but it's intermittent awareness. And Bruno in 2009 identified that this is a huge diagnosis, minimally conscious state, and it needs to be considered in terms of 2 subdivisions. So we have minimally conscious minus, which is at the lower end of the condition, and that's people looking towards or moving towards a stimulus, and minimally conscious plus, which is the higher end, which is where you may get much more interactive responses. So somebody might be able to press a switch, they may be able to follow command, they may have a thumbs up for a yes, but it's not reliable at this stage. So in terms of the SMART and PDO assessments that we're going to talk about today, we're really looking at these 2 diagnoses, but we also need to consider the patients that are in minimally conscious state but may be emerging. And that's another issue and another type of diagnosis. So we will talk about that as we look at the levels of SMART. So SMART is really looking at these 3 areas. One of the issues with diagnosis is that in PDOC is that there's a huge range of misdiagnosis in this condition. So in 1996, Professor Andrews at the Royal Hospital for Neuro-disability did a study which looked at the amount of misdiagnosis that was occurring, particularly in sort of vegetative state, but also minimally conscious state. And he used the SMART assessments to look at what somebody was assessed on admission and on discharge, and what the differences were. And he found that there was 43% of patients were misdiagnosed, which is incredibly high. That was in 1996. The difficulty is that in 2015, there was another piece of research that was carried out, and they found that it was still at 39%. There's also been one in 2009 looking at 41%. So we're talking about a rate of misdiagnosis that really isn't moving very much. And that's a real issue for our patients, because a misdiagnosis can have quite devastating consequences. So when we're looking at SMART and we're considering all the things that we put around SMART to try and make it as robust as possible, we're trying to reduce this issue of misdiagnosis. So the SMART is a sensory modality assessment and rehabilitation technique, but it's always referred to as the SMART. It was developed to identify a detailed account of a person's responses, so what they're able to do and how they respond. And it was also be able to indicate where they are on that spectrum in terms of their diagnosis. And within diagnosis is where they also are, because there is a huge range of responses. It also provides an evidence base to intervention and management plans. So it's not just an assessment, it's not just creating a score, it's about what do you do with that score, what do you do with the levels that you have in order to move ahead with that patient. And that might be in terms of management, it might be in terms of rehabilitation, but it's about having a very focused way forward from the assessment that you're doing. And I think that's a really important aspect with these clients. So in the development of SMART, we had some clinical questions. So the first one was, what impacts on patients' responses? What is it that affects them? Are there things that mask responses? And so it's not enabling people to respond to their best ability. Are there things that are stopping responses? And Helen's going to talk about those. And that's in a part of the assessment called the Spec. And she'll be explaining that in a minute. So that was our first question. Our second question was, what behaviours are present before we do anything? And this is an important thing to consider, because sometimes responses are attributed to a stimulus that are actually there without the stimulus. And that's why we need to understand what the patterns of responses are and understand the type of responses that patients are doing. And we have the behavioural observation, which is part of the SMART. As well as identifying their patterns of responses, it also helps us to see responses that might have potential. So if a patient's moving their head when we're observing them, could we use that head movement to see if they could press a switch with their head? Could we use it to target in localizing? Can they look towards by turning their head and turning their eyes? So it's helping the clinician to understand the patient's responses in order to know what they currently do, but what could we also work with? The main part of the assessment is the sensory assessment, and that's really looking at what the patient responds to and how they respond. Do they respond to a specific sensory modality? Do they respond in a delayed way? What type of responses do they have? And how frequent are the responses? Then we have a slightly adapted area in the version 3. We've worked quite a lot on how we present the analysis and how we present the data to create profiles for patients, because we noticed that in our work that we're doing in the medical legal field and also in assessment units, it's about looking at the trajectory of patients over time. So has there been a change? Is that upwards? Is it stable? Or is it a deteriorating trajectory? And so we wanted to try and show that in the SMART. So it's about, in version 3, we've looked at how we use the diagnosis and the data in order to present it to show change. And I think that's much more useful for the stakeholders that are interested in the assessment. And then the other area, which was really important when we were starting SMART in the new brain injury unit, we had families that were very involved in the development of the unit, the processes, the day-to-day life. And so when I started developing SMART, I was really adamant that we had the family and team aspects in there. And I think they're a really important part of what we do. And I'm going to talk a little bit about that later. And lastly, as I've already mentioned, it's about what happens after the assessment. And that's key, obviously, for clinicians, but also for case managers. We have this identified diagnosis, we know what they can do, so what? What do we do now? Families want to know, what do we do now? And that's why we have intervention and management strategies as part of the assessment process. So before we go on to the assessment, it's important just to have a quick look at assessors. And one area that we have constantly been criticised in terms of the SMART is that we require assessors to be accredited. And we've been challenged quite a lot on this and asked if we can just provide it as a tool that anyone can pick up and download from the internet. And we've said no. And most of the reasoning for that is because of the misdiagnosis that we talked previously about, that it's important that you have skilled assessors, that you have people that are that know the client group, that know what they're looking for in terms of types of responses, that know how to use the tools. And so we have a very set format for accredited assessors and how they get accreditation. And I've mapped it here to the person spec that the RCP have put out on their annex to the guidelines. So it's Annex 2B, it's the electronic annex. And on the right-hand side of this screen in the blue, you'll see what their person spec are requiring. On the left-hand side is what we do in terms of SMART. So we require assessors before they come on the course to have certain experience and qualifications. They undertake a 5-day course where they look at the diagnostic criteria. They have practice on assessment. We look at how you classify assessments and observations. They then go away to their workplace and undertake a SMART, which is a non-accredited accredited SMART assessment. They complete the SMART template for the report, and all the time they're doing the assessment, they're doing the analysis, and they're writing up their SMART. They're doing it under mentorship, and at the moment Helen and I are mentoring all of the assessors. Currently we have 105 accredited SMART assessors. 3 of them are at master level, 3 are experts, and there are 13 advanced. And we recommend in our accredited assessor standards that you need to be at least advanced level in order to do medico-legal assessment work. And that's because somebody at an advanced level has a history of experience with PDOC. They'll have done some research or service development in relation to PDOC, and they will have met all the criteria and quite often do some of the teaching as well. You can, if you're interested in whether somebody is accredited, there's a list on the RHN website, and it'll also give you definitions of the different levels of accreditation. So SMART profile is it's an investigative inquiry. The newest version of SMART is really formulating a lot of the practices that we've done previously and making a lot of them mandatory. We have standardised and non-standardised elements. We have aspects for clinical reasoning, which is where the clinician will be able to use their knowledge of the patients to make some decisions on the aspects of the assessment that are used. It also has flexibility to be able to use things that are familiar to the patient in contexts that are familiar to the patient. So we're starting to look at all of the information to understand the patient as best we can. And SMART was really triggered by a book by Dr. Freeman, an Australian neurologist who wrote a book in the 1980s on coma. And he talked about working with this group of patients, with patients in vegetative state, minimally conscious state, is about detective work. And it's about trying to find the evidence for what they're doing and for what you intend to do. And so that's what SMART's about. It's about gathering the evidence and trying to find out more that we can about the patient, and then what we can do for the patient. So the organisation of SMART is that we do 10 sessions. It completes 1 SMART assessment. And those 10 sessions are divided between morning and afternoon. There's 1 assessor, and there's 1 to 3 weeks to do the assessment. The 1 assessor allows you to get 1 person really knowledgeable about that patient so that they can pull together all the evidence. So I'm going to hand over to Helen now. Helen, you.
Thank you very much, Karen, and to echo Karen's thanks to all of you for joining us today. As Karen said, SMART is an investigative tool. The detective gathers the evidence and sees the patterns. So I'd like to draw a parallel with if you had a fracture in your arm, you would go and see the doctor and they would look at it visually. Then they would talk to you and talk about the events, but they wouldn't stop there. They would do a deeper investigation. They'd send you off for an X-ray or a scan. And these here on the screen are those investigative tools we use for SMART and PDOC. We want to do a deep investigation, make sure no stone is unturned. We take the assessment process very seriously. So here we have the first part, which Karen talked about, was the SMART pre-diagnostic criteria, which I'll talk about in a minute. Then we have the formal aspect, the behavioural obs and the sensory assessment, and then the family and team perspective. Thanks, Karen. So what we're looking at here is what we call Spec. And basically this is looking at the patient and their environment before you even start the assessment. And we do this for all of the sessions. So we have 10 sessions and we check it out in every single one of them. And then we'll do an overview as well. Because what we want to do is see, is there any impact of these aspects on the patient during a day or during the 10 assessments that we're doing? And how can we address that? So the wording in red looks at what is just specific to SMART. Some of the other assessments do cover this, but this is very specific to SMART. So we'll look at the patient's medical stability, and certainly we'll ask the lead doctor to confirm medical stability and readiness for the SMART assessment. We'll look at medication, that they will confirm that the medication they're on isn't unduly going to make them sleepy. We'll also look at their tone. You know, is there issues about their tone management? For example, if there's some suspects, some evidence of some upper limb movement, is the tone being managed, or is it something to be looked at, or does it need looking at? Look at positioning and wheelchair seating systems as well, and look at their sitting tolerance. The number of times Karen and I will go to a case, and the patient basically spends a lot of the time in bed. And we need to look at that, because if they can't get out of bed, they're not exposed to the environment. And we'll look at the environment and see where are they going to during their day, how many different environments are they in. We'll also look at pain and mood. And there's obviously some really clear guidelines on that in the RCP guidelines. But like I say, we'll look at those every day, and then we'll see the impact on the types of behaviours exhibited and also how they respond to us in a sensory programme. Thanks, Karen. SMART is the only PDOC assessment which will provide an extensive report at the end of it with actions and management plans. So it's all about how we move forward, or how at least we manage what's happening with the patient. And it'll look a little bit like this in the report, but basically it'll look at different aspects which we think need addressing. And it might be things like further visual and auditory investigations to ask the doctor if that's indicated. We're looking at whether the sitting tolerance needs increasing, for example. Do they need a bespoke sensory programme which needs to bring in familiar stimuli? Do they have postural management guidelines? Are they being positioned correctly in bed or in a chair every day in a consistent manner? Specific issues about headrests or types of adaptations, and provide orthotics, for example, for upper limbs. So if they haven't got a very strong team around them who haven't got certain expertise, perhaps we can help advise in that area. But certainly, for example, in the M case, when I assessed that client who was originally diagnosed as being vegetative state, she'd been in bed all the time for the assessment and what have you. Once we sat her up for SMART, which we do for every single SMART assessment, or at least positioned optimally in bed, the diagnosis changed to minimally conscious state. So all these aspects are essential to the client being able, the patient being able to show their potential and what they can do. And it's up to us to be able to optimise those criteria. Thanks, Karen. So I'll give you an example of where the Spec aspect was really important with one case. Now, I was asked to assess a 9-year-old child on a specialist unit, and it was for potential application for withdrawal of clinically assisted nutrition hydration. And she had a diagnosis of vegetative state at that time. Obviously, we informed the lawyers that SMART isn't validated for children, but there are no other PDOC assessments, and they were keen for us to move on with that. And obviously, we asked for medical opinion on the status, and the lead physician said they were optimal. I started off 2 days, I did 4 SMART assessments, and the client was unarousable and non-responsive. So if I'd have just carried on not considering anything to do with the arousal levels, she would have definitely come out with a diagnosis of vegetative state. But like I say, SMART is about doing an investigation. It's about asking questions. So we went back with the lawyers to the lead physician, and he reported in a report that medication impacting on arousal was prescribed for pain. But we obviously then clarified that, because the perception of pain requires awareness. So if they were saying she's vegetative state, she couldn't be if they were using this medication for her pain. So that they reviewed the medication and we recommenced SMART. Certainly it was a completely different presentation when I went back again. Her eyes were open, she was consistently tracking up and down, and it was also observed when we went in to work with her in hydrotherapy with a physio, because as Karen said, we bring in the team and the family to try and ascertain where are these responses being seen elsewhere. And then application was withdrawn. It was very clear she wasn't in vegetative state, and an intervention program was provided using eye gaze technology and more sort of varied therapeutic intervention. So it completely changed the diagnosis for that client. So again, as we layer that evidence, the next investigative tool we are using are the formal assessments. And as Karen said, we use the behavioural observation assessment and sensory assessment. We'll do that 10 times. So we start off with the behavioural observation assessment. In those 10 sessions that we do, we'll do 10 minutes observation of the patient at rest. So that is just observing, and every 10 seconds we'll write down if the patient has moved or not, and if their eyes were open or not. And then if they have moved, we write a very, very clear definition of what that movement is, so it's very clear to anyone else who sees that patient. So the report again will provide this information and will summarise the result. But for example, it will talk about, here you can see the eye opening and closure rate. So this is talking about the number out of 300, but you also can get a percentage. It says a percentage time for eye closure and eye opening. And it also, as you can see across that top line, you can see that you can look at whether it's when they're in sitting, whether it's morning or afternoon. So you can see when's it more optimal with the eye opening and when should we look at interventions. It'll also, as you can see there, look at no movement, and it'll also look at the types of movement you've got. So you can see in those columns, you can see that each of the movements have been subdivided into whether they're purposeful, reflexive or spontaneous. So this patient had 23 behaviours. Of those, 14 were reflexive and 9 spontaneous. And as Karen said previously, what we can see from this is the spontaneous behaviours are head movements. So as we're starting to get to know this patient, you would think that movement doesn't happen all the time. It looks more it looks more spontaneous. It's not reflexive. Can I start to investigate that with use of asking them to move to instruction, use of switch on the left, right, back? And if I hadn't seen that patient the same time over 10 sessions, those patterns would be very hard to identify. So that's the use of that tool. So that information would be in the report. And like I say here again, the red is exclusive to SMART. So certainly some of the other PDOC assessments do a short behavioural observation. They might look at the type of behaviours. But SMART will look at all of these aspects, the frequency of those behaviours, behavioural groups. It'll definitely look at eye movement, patterns over time, and it'll also look at eye opening, AM, PM, and all of those things on the list. And the total behaviours over the 10 session per session to identify any patterns. Well, when I talk about the eye movement as well, not only are we asking are the eyes open or closed, we also look at over those sessions, where are the eyes looking? And if there's a pattern, we can record that. Thanks, Karen. So here you can see that in this slide, this shows that morning and afternoon, the eyes were closed more in the morning than the afternoon. So in your intervention plan, you might think, well, if I'm going to do something that needs to engage the patient, I might look to doing that more in the afternoon so we can get a little bit more interaction. Okay, thanks, Karen. Okay, so case study 2 is another example of where the SMART behavioural observation programme was very useful. It was a case that went to the courts, royal courts, and the family were very strongly opposed to clinically assisted nutrition hydration being removed, and they cared for this patient for many years at home. So now the patient is now on an ITU unit, and the intensivist, who obviously highly experienced at what they're doing, had made a decision to apply for withdrawal of clinically assisted nutrition hydration, but he'd never had a proper PDOC assessment. Because of the sensitivity of the issue, we conducted the assessment, and we videoed the behavioural observation and the family observation sessions because of the sensitivity with the family. So that we had a professional cameraman, and we videoed every single thing that there was in case something was identified. The family, basically their key issue, once we interviewed them, reported visual localization to interaction on the left and right. So they used to stand on one side of the patient, he'd look at them, then they'd move around after 2 minutes to the right-hand side and do the same, and his eyes would move over. But if we looked at the behavioural observation videos, i.e. at rest with no stimulation, and then we worked it through with the family, we recognised that the eye movement pattern at rest sustained to the left for 2 minutes, then looked up and over, and then to the right for 2 minutes, and then that repeated. And I worked through with them, asking them to just watch him at rest and not to do any intervention. And, you know, we spent a lot of time together going through this. This is where Karen will talk about the involvement of the family, is getting them on board and listening to what they're saying and then investigating it. But actually on the day of the court, when they thought there would be further opposition, the family withdrew their opposition, obviously having been taken through the process and having very objective assessment. The brothers spoke very positively in court about how SMART had included them, and its careful exploration of families' beliefs and views was useful. So SMART is a sensory assessment. The SMART sensory assessment immediately follows a behavioural observation assessment. It has 16 core techniques, which include vision, auditory, tactile and olfactory, and then 6 advanced techniques, including gustatory. So for example, in the core techniques of vision, we look at visual tracking. Can the patient follow a mirror, a photograph and a familiar photograph, left, right, up and down with their eyes? Do they look left? Do they look right? Do they look up? Do they look down? If they can do that, we might progress on to the advanced techniques, which would be things like visually differentiating yes, no cards, blue, yellow cards, or following written instruction. If they're not doing anything in vision, which, as Karen said, in Dr. Andrews's paper recognised that 65% of patients had no visual ability. If there's no responses in that modality, we wouldn't move on to those higher level responses. Each technique has very clear instructions, and it scores a full range of responses observed. You know, we want to know, is it delayed? Do they just look left? That type of thing is very important about how we present stimulus, our knowledge of the patient. And SMART's the only assessment which will divide up their motor function, i.e. their movements, or their communicative functions. And the responses from both of those areas can be different to each technique and each modality. The other unique aspect about SMART is that we look at verified and unverified responses. So verified means if you've seen tracking and you're absolutely certain it's there, that can contribute to the diagnosis. If you see something you think, oh, they're glancing, I'm not sure, the assessor has been trained to query that and have it as an unverified response. And if they're still not sure at the end of 10 assessments, that's fine. It might be an area to explore, but we can't have guesswork in SMART. It's definitely there, or it might be there. If it might be there, we're going to look at it further. Right, so SMART is the only tool that looks at the 5 levels of SMART. Sorry, so it's gone. Can you just go back a bit, Karen, just quickly? Sorry. Okay, yeah, and you can see there's 5 levels for SMART for each modality. Thanks, Karen, that's great. Okay. Okay, so SMART is the only assessment that will not only divide up motor and communicative responses, but it will also divide up minimally conscious state. Now, as we talked about this, we've got MCS minus responses, and we've also divided MCS into hierarchically layered responses from lower, mid, and upper. So you can see level 1 to 3 all indicate diagnosis of vegetative state. Now we say indicative because obviously our assessment will go to an expert physician who will review. So we're saying these are the responses we've seen. So 1 would be they don't respond, 2 is reflexive, 3 is withdrawal, very reflexive, and 3 non-meaningful communicative expressions. And then you can see how it divides up moving on. So you have localizing motor responses or a meaningful communicative expression. And then you can see the different levels there for MCS, and that's lower, mid, and upper, each of those. We have got more detail on what fits into each, but that's an overview. And 6 is not validated, but it's when it can be confirmed by another team member that the responses seen meets the criteria. Okay, thanks, Karen. Thank you. So as an example, like I say, we have visual, auditory, olfactory, visual, auditory, tactile, and olfactory, but we've pulled out here 5 techniques which are in the core auditory. So we have, for example, very basic ones, first of all, which could be response to loud sound. So you can see here, for example, you might get a startle response at level 2. You might get a head or eye turn towards sound at level 4. In the motor, and then in the communicative, you might get another response, which might be a smile as they hear the sound. So you pulling out all of the responses to every single stimuli given. A paper by Godbolt et al. Was the only clinically reported review of how each assessment looks at and diagnoses patients, and it looked at the CRS and the SMART. And of those, 6 out of 10 agreed in terms of what the SMART and CRS found, but 4 out of the 10, the SMART found minimally conscious, where the CRS didn't find any responses. And a lot of that was to do with the fact that the assessments done by the same assessor over a long period of time. It is all about the durability of the assessment, the frequency, and also the techniques that picked it up was the use of the switch written instruction, which is unique to SMART. And then obviously the verbal instruction was useful as well, because the assessor knows what sort of questions to ask that person to do. So the categories and frequency of durability of SMART are the highest inconsistent responses. And we're looking at over the 10 sessions is 2 to 4, basically. 1 is unverified. If 1 occurs 5 times or more, but not consistently, it's frequent inconsistent, and a consistent response is 5 in a row or more. And from that, you can create a profile. Thank you. Next page. You can create a profile, as you can see here, and you can see how you can start to see what level are they and what frequency is that response. And you can do that for both motor and communicative response. Thanks, Karen. And then this is all put into a grid, which again is in the report. It's quite complicated, that, but you can see down the left column, he's not responding visually, but at the top, your motor responses, you get a very clear description of what they can do. And then beneath that is the functional communicative responses. and you would get a clear information about what they can do there. Thanks, Karen. In the report, you'll see a table, and you can see in this one, M is motor and F is functional communication. For motor, you can see a level, vision hasn't shown anything, so it's diagnosed as a VS for the visual responses. But because SMART can tease out auditory, tactile and olfactory, you can see she's done a yes-no response, not meeting the guidelines. So MCS plus upper, and obviously MCS plus mid for the motor. And the tactile and olfactory gave us MCS minus response. Thanks, Karen. And then just briefly, as Karen said, there's optional non-standardized elements of SMART, which is investigating for further evidence. That's deeper exploration. We meet with the family and team and go through responses and try to establish what they've seen. Karen will talk about that later. And we'll observe those with the family or team and say, show me what you're seeing, until they're happy they've seen it. And then we'll also find, oh, sorry, just go back a minute, sorry, Karen. And then we'll also look at functional exploration techniques, which is, as you can see there, the list of those, which we found actually teased out more and more responses. So let's say, for example, cause and effect. You can, for example, have a movement up and down of the arm. They might not follow command, but you see something purposeful. You can see if they can activate an iPad, for example, and use your knowledge of the patient to elicit that. And certainly exploring the emergence techniques is done very systematically as well. Thanks, Karen. And so you can see here how layering the evidence, again in red, SMART is the only tool that will look at MCS minus, lower, mid and upper. It will look at per modality for motor and functional, and it will look at unverified, which need exploring later on. And it will look at the frequency and durability of those responses and feed that back in the report. Thanks, Karen.
So moving on to the last aspect of SMART, that's the part where we include the family and the team. So this is unique to SMART. It's a mandatory element. We ask clinicians to do face-to-face interviews where possible, so that you can understand the type of response that the family or the team member or the care team member are reporting. What we then do is we put it into a grid similar to that Helen showed you for the sensory assessment, and we allocate SMART equivalents to it so that we can compare what's being seen outside of the SMART, what's being seen inside the formal SMART. It allows us to also understand a little bit more about the responses that are being discussed. So what we're able to do is we're able to map it against what we see on the SMART. So this is one of the profiles that you would get in a SMART assessment. The red is the formal SMART assessment. So you can see here that we found that somebody is responding to at the upper end. So they were able to use a comb and a toothbrush once they were positioned. So we got the upper limb supported by cushions and wedges into a position where they could then reach their head and their mouth, and they could demonstrate the difference between the two objects and that they could use the two objects. But it wasn't on a consecutive sessions. The family and team reported that the highest that person did was move towards an object. So if something was on their wheelchair tray, they'd move their arm towards it. So we're able to see that there's a difference here, and the difference is about facilitation and the importance of being able to get your hands on the patient, try different positions, try and look at what's going to facilitate the best response. And so once we were able to identify that that could be done, we could then show the team, we could then show the carers how they might do that for teeth cleaning and personal care. You can see there's a difference here in functional communication. So in the SMART, we're still in the same level though, we're still all at level 4, but the frequency is different. And this was a smile that the person did that was an appropriate smile, appropriate to the situation. We'd seen it a couple of times in the SMART, but the family reported that that person always smiled when they greeted them, when they arrived, when they were doing family things. So that's not unusual that the family might see more of that response than we would see in the formal assessment. So it's giving us a good idea of what's happening. So if we're looking at the evidence again, we're getting the family and the team perspective. We understand that the equivalence so that we can compare. The other thing that we're getting, though, is understanding the language that people are using in order to report responses. And that's really useful because sometimes there can be a difference of opinion between teams. And there was a study by Edgar that looked at the different perspectives that teams and family are looking at the patient. And that's why there's usually a communication breakdown when there are problems. And so understanding how people are describing it and whether it's the same response but spoken of in a different way, or whether they're describing maybe a reflex response that's spontaneous or vice versa. So it helps us to understand maybe the work that needs to be done either with the team or with the team and the family at a later stage. So it's good understanding of how people talk about the person in disorders of consciousness. So as we said, we've got all of that information. It gives us a diagnosis, which is important. It gives us a place on the spectrum, which is perhaps even more important clinically to understand exactly where they are in terms of particularly minimally conscious state. But what do we do with that? So we look at is the issues that the issues that we're going to look at management, or are they intervention? Management might be things like establishing a 24-hour posture care, or it might be establishing a monitoring system that can help maybe a case manager to evaluate changes at annual reviews, to really look at any changes that happen. So it might be that the focus is setting up a management phase or management issues, or it might be that you're looking at investigating something a bit further, providing rehab, providing intervention, or there may be a combination of the two. So if it's clinical, we would get, the assessors would identify exactly what they feel needs to be focused on in terms of enhancing or increasing that person's responses. And one of the things that we found that often trips clinicians up is that they jump too far ahead. So trying to get communication when somebody perhaps isn't sustaining visual localization on a person or on a yes/no card. So it's about making sure that things are staged, that you make decisions on, are you trying to increase the frequency that somebody's doing something, as in the top example, or are you trying to increase the complexity and the level of responses, which is the bottom example. So in all of the intervention plans, we're looking at things being very measurable, being time bound, so that we're not saying that therapists are there forever, but they're there to do this, then they review it, and then they decide what the next goal and aim is. So it should all be measurable, and I think that's a good focus of the SMART. This is the overall of the SMART report and the elements that you would expect to see in it if you were receiving a report or if you were undertaking report as an assessor. Okay. So benefits of SMART. It's about having the pre-diagnostic information, meaningful responses, creating a profile, understanding the verified and unverified responses, giving placement on the diagnostic spectrum so that you're very clear where that client is, and providing evidence which will then underpin the clinical decisions, whether that's in best interest meetings or whether that's in courts, in court of protection, and also underpinning goal setting so that it's very clear that the focus of the next stage of intervention with that particular person. So thinking about the tool selection that I talked about earlier, one of the things that we're quite clear about in the work that we do is that one assessment doesn't fit everyone. SMART is a very in-depth assessment, and there are conditions when SMART is the best tool to use. But there are other situations where it might be that you combine assessments, and there's some papers that are suggesting, there's a paper by Morrissey et al. That suggests bringing the WIM, the Wessex head injury matrix with SMART is a good combination, because the WIM helps to monitor the situation, and the SMART gives you some in-depth information about responses. So bringing assessments together is an option as well, particularly clinically. It's thinking about, what do you want as a stakeholder of the assessment? What is it that you're wanting from them? And where is the patient? So has there been evidence gathered? How specialists are the team working with them might inform the type of assessment that you're using. What is required from the assessment is something that we're all also try and push in our SMART course, because it's about deciding what do you want from the assessment, then you decide the assessment that's most appropriate. So if you want a diagnosis, then you might go for the CRS. If you're wanting in-depth information about the types of responses, the diagnosis, and then what you do, you might use the SMART. So depending on what you're requiring from the assessment, depends on the tool that you use. So this just is a table form of the different things that you might gain. So we've got PDOC assessments that will give you behavioural observations. It's usually a minute of behavioural observation before the intervention, the assessment. They do an assessment over time. For example, the CRS used to be one assessment only, but now they've done further research and then they're suggesting 6 assessments. SMART has always been 10. We do the 10 assessments because of it being able to reflect the variability of somebody in a vegetative state or minimally conscious state. Obviously, the SMART will give actions, it will give a report, it will give comprehensive placement of the patient on the spectrum, but you can have other assessments that will give you whether that person's in vegetative state or minimally conscious state. So it's about choice, it's about understanding the assessment. The RCP guidelines have a full outline of what the key features of different assessments are and when they may be applied. So that's always a good guideline to go to. So we hope that you've got a sense of what the SMART is. We do have SMART courses coming up. I think there's one in October, but Anna might be able to correct me if that's wrong. The SMART courses are Zoom at the moment. Gilthwaite and Elliott also run a PDOC one-day observer and facilitator course, which we often do in the workplace with teams. And work on how they observe and monitor and record and how they work with somebody. It's a framework that we provide for PDOC. There's an assessor list on the website, and if you've got any queries about SMART at all, the contact details are below, and for Gilthwaite and Elliott, the contact details are at the bottom. So thank you very much. I don't know whether we've got any quick questions, Anna?
Yeah, we've got a few, so thank you so much. So just to recap, the next online SMART course starts on the 6th of October. It's 5 days. We've split it over 2 weeks because obviously we realise it can be quite intensive. So rather than doing 5 days in a row, we split it over 2 weeks for you. We also won't be able to make these presentation slides available, but the lecture is being recorded and it'll be available on our website from Monday. So if you'd like to watch it back, or if you have any colleagues who've missed it, do let them know that they can find it on our website. So we've got a few questions. If anyone else has got any questions, do pop them in the Q&A button. So the first one's from Joanne. Can SMART be completed with patients who don't have a neurological diagnosis?
It's obviously difficult without knowing exactly what those diagnoses might be. Usually it's used for neurological diagnosis. It's validated for people that have had brain injury and from 16 and a half upwards. We have used it with dual diagnosis. So we've used it with people that have had brain injury plus learning disabilities and other physical disabilities and mental health disabilities as well, combined with brain injury. It has also been used with patients, with children with PMLD, so with profound learning disabilities. And I've also used it with somebody that had later stages of multiple sclerosis because there weren't any other forms of assessment, and we used it in an slightly adapted way. So it is a neurological assessment, basically. But if she has queries, maybe she could contact us and we can talk a little bit more about that.
Thank you. And the next question is, if you work in a general non-neurospecialist acute hospital and feel a patient may benefit from a SMART assessment, how would you go about this?
There are different ways that you can go about it. So I guess that's come from a clinician. You can refer your patient to a PDOC unit, and that's probably the best option to start with, particularly if you're looking at the whole package about looking at positioning and drug regime, and actually get the whole specialist approach to the patient. I would refer to PDOC assessment. There you can privately commission a SMART assessment. I don't know how other people work, but Helen and I would always look at what was best for the patient as to whether they had been fully assessed in the first place, and get them to a PDOC unit first, which I think is the best option. Okay. Or you can train as a SMART assessor, obviously, and do those in your workplace.
Absolutely. The next question is from Inga. Would all discharged patients from the RHN have had a SMART assessment?
Helen, would you like to answer this one? You need to unmute.
I think the answer is no, because I think they will assess which specific PDOC tool is applicable for that client, and the very specialist team will make a decision on that in terms of which one would apply for that particular case.
Okay. And I think this is a question again for Karen, from someone anonymous that said, you said that you thought there may be other assessments suitable for a particular situation. Do you carry those out?
We have used, normally we're asked to do the SMART, but we have used the WIM and the SMART as a combination. Helen, have you used anything else?
I haven't used, no.
No.
But we could. We have got.
We could do
that.
Usually we're asked to do the SMART because it's required that they want something that's in depth and has recommendations at the end. So obviously, from our perspective, that's the most appropriate one. But sometimes we use the WIM alongside, particularly if the WIM has been used previously over that person's journey through the different units that they may have been at. So that would give us a baseline before, and it help us to look at what previously has been seen and what we're currently seeing. So we may use the combination.
Oh, so Sophie has said the MATADOC, for instance, could be used if the patient is responding to music. So the MATADOC assessment tool.
Yeah, I think that absolutely the MATADOC. That's another assessment that was developed at Putney, wasn't it, at the RHN? It's by music therapists. So you need to have a music therapist and a response to music in order to carry out the MATADOC. But it is an option, yes.
Thank you. And another one, are PDOC AX tools, is that PDOC assessment tools repeated as part of a follow-up review?
Yes, they can be. It depends where. We sometimes do repeat assessments maybe a couple of years later if somebody is showing some changes. So one of the key things that's important with somebody in PDOC is that there is some form of monitoring of responses so that you can identify if changes are occurring. And if changes are identified, then another assessment may well be indicated.
Can I come in there as well? I think as well we need to try and steer away from over-assessing the patients. And I've been to quite a lot of cases where patients are just continually being assessed. And we do have to be really careful that we're doing the assessment for the right reason. And, you know, it's not just a reason because they don't really know what else to do sometimes. So I think it's really important to think about, what are we trying to say? Has there been a recognised difference? Has someone seen something that's different? What's the reason for the assessment before we subject the patient to a series of other assessments?
Yeah.
Okay,
I think, you know, if you are going to do an assessment, you need to then think what you're going to do with that assessment result. And again, we have seen quite a lot of patients that have had assessments and the assessment sits in their notes and there's no consequence of that assessment. So I think it's about thinking about why are you reassessing and what are you going to do as the next stage after that assessment.
Okay, thank you. Well, the next one, it's not a question, it's from Richard, just says, thanks for the useful talk. So glad you enjoyed it, Richard. Thank you. It's 2 o'clock, so we're out of time. If you do have any further questions, do get in touch with us. Karen's left up the email address, so do get in touch with us at smartrhn at rhn.org.uk, and we will come back to you as soon as we can. So thank you very much. Just a reminder, this talk is being recorded, so we will have it on the website next week, and hopefully you can join us again for another lecture. And thank you to Karen and to Helen for joining us.
Thank you.
Thank you.